I welcome you to this webinar, Cardiology 101. Today we're talking about chest pain and what else it could be. I'm Nicholas Hodgman, an interventional cardiologist at Mercy Medical Center. And you can see right off with our picture here, typically a cardiologist would think that the heart is the only thing in the chest, and today we'll veer from that truth and talk about maybe other things that chest pain could be. Of course, the heart's most important, and I refer you to some previous webinars if you want to know more about threatening heart attacks and chest pain that represents heart attacks. Today we'll focus on what else chest pain could be in hopes of helping all of us know when we should go to the emergency room, when we should call our doctors. Today we'll discuss, again, different definitions of chest pain. We'll talk about the nervous system and where chest pain comes from. We'll talk about when to call 911, and we'll talk about what are the causes, different causes of chest pain. First off, you can see on the right with this picture, chest pain that's related to the heart comes from narrowing of the heart vessels, the heart muscle not getting enough blood. And on the right, you can see there's a narrowed off vessel, and that blood vessel is feeding heart muscle, and when that heart muscle doesn't get enough blood, that results in chest pain. Heart pain is called angina. Someone who has angina is always someone who has blocked or partially blocked blood vessels in their heart. Otherwise, we have to take all chest pain seriously, and from the myriad of complaints that patients may present with, we take anything basically from the ears to the belly button could be considered chest pain or related to the heart or some other organ or tissue that may be causing pain. So we see a wide variety of symptoms, and so typically if you come into the ER or see your doctor and you complain of jaw, arm, elbow, anywhere in the chest, he or she may be counting all of that as potential heart attack pain, and we'll talk more a little bit about that. One thing to note, which is important, is that the nerves that come out of the spine and the pain sensory nerves, nerves that pick up pain, work in kind of a broad area within the chest. So, for example, like we talked about earlier, sometimes real heart pain can be felt in the shoulder or the jaw, even the ear or teeth, the arm. This is because the nerves are not specific nerves, not like in your fingers or your hand wherever you touch, you can feel exactly where that's at. That's not how it works on the inside of the body. It's much more general. So the brain knows, oh, there's pain coming from the heart, but doesn't know, has a hard time telling where that pain is coming from, meaning it's referred pain is what we call it, meaning the pain could be in different spots. And here you can see on the right, even the skin sensory, you can see that it's spread wide. There's one nerves related to that whole zone on the skin, and much of that is how it is on the inside of the body. So, for example, people who have, say, a gallbladder attack, some people feel that up in their shoulder. So the nerves on the inside of the body are not nearly as able to locate where the pain's from as on the skin. This is from a study of primary care doctors who see chest pain in the office and how often they see chest pain and what it typically ends up being. So we'll go through each of these. Notice the highest prevalence is what we call musculoskeletal. That means that's chest wall pain, either from the muscles in the chest wall or the ribs, or cartilage in the ribs. We'll talk a little bit more about that. Then look at the stomach and esophagus, represent the next highest diagnosis people come in with chest pain, and then third is the heart. Of course, now the heart is obviously more dangerous and more important than the two ones above, so that's why almost every physician or provider of care will consider the heart and make sure the heart's safe first, at least they should be, before signing off the chest pain to one of these other diagnoses. because we don't want to miss heart attacks. So let's just pause here and just put a statement in, or when is it an emergency? And the heart has some pretty classic symptoms, despite rumors throughout the media. They're pretty much straightforward, especially if it's a severe heart attack. Remember, anytime you have chest pain that's related to exertion, that's undeniably the heart. So if you go out for your daily walk with your dog and you're getting chest pressure, and every time you go out, every time you go outside, you feel this chest pain, and then it goes away when you stop walking, then you will know that that's from your heart, and that is something that you need to see a doctor about. Now, if you are just sitting around at home and you have symptoms all of a sudden, and those symptoms include these things that are described in this picture on the right there, you'll see that what you look for is not just chest pain alone. Of course, there's always chest pressure of some type in a large heart attack, but it's almost always related to other symptoms, including a shortness of breath, nausea, and sweating. Those would be the three big ones. Of course, people get other things in their jaw, tingling, and sometimes pain in the arm. But if you ever have chest pressure and you feel nauseous and sweaty and you're short of breath, that is an emergency, and you should call 911. We have seen some unfortunate cases of people staying at home with their pain through the night, being sweaty and short of breath, not thinking it's a heart attack. And of course, with the heart, time is muscle, meaning if it doesn't get fixed fast, you lose that muscle in your heart and you cannot get it back. So it's always important when you have these severe symptoms to report to the emergency room or call 911 and not to put it off. So the first non-heart chest pain diagnosis we'll talk about is costocondritis. That just means an inflammation of the ribs, specifically the rib joint, where it joins the middle of the chest bone there, the breastbone. This is a common finding. Usually happens after people working in the yard, doing some heavy lifting, or doing something a little out of the ordinary. Even if you're a little sick with a virus, sometimes these can be inflamed. And typically, you can tell it apart from heart pain because it's there all the time. It doesn't really go away and come and go, especially if you're, say, exerting yourself, going up a couple flights of stairs. Doesn't make it worse. It hurts at the bottom, hurts at the top. Of course, with heart pain, you'd feel good at the bottom of the stairs and you'd feel bad at the top. That's not a good sign for the heart. But with this, it would hurt all the time and be much like an arthritis pain, but in the chest. Basically, this diagnosis is usually after you've ruled out everything else. So typically, when you present to the ER or your doctor, they don't just say, "Oh, you have costocondritis." They should always make sure it's not a threatening heart attack first, and some other serious things, which we'll talk about. But this is the most common that people get, and easily treated by rest and ibuprofen, if you can tolerate ibuprofen. The next most common is from the esophagus. If you look at this picture on the bottom, you can see the esophagus runs very close to the back of the heart. They're closely associated. Even part of the heart touches the esophagus. That's how close they are. So pain from the esophagus, the brain has a hard time telling us if it's the heart or if it's the esophagus. It's all signals get a little mixed-matched, and that's why we see a lot of chest pain that comes from the esophagus. And there's a couple different things. The esophagus is a muscle, a long tube of muscle that can spasm, like any muscle can spasm, almost like a Charlie horse in the esophagus. You can also get inflammation in the esophagus, which we'll talk about. And of course, acid reflux and heartburn, the most common issue with the esophagus, which we'll talk a little bit about. Esophageal spasm is when this tube of muscle squeezes down when it shouldn't. It's actually pretty rare, tough to diagnose. Here you can see a patient has had to swallow some disgusting x-ray dye in order to pick up, and you can see there's some crimps in the esophagus where the muscle has really clamped all the way down. And this just can occur randomly. It can also occur when there's acid that is coming up from the stomach and triggering the spasm. Usually causes pretty severe pain. Medicines that help the heart can also relieve this pain, so it's tough to tell the difference between the two, which is why we always make sure there's no heart attack first. Then we can maybe blame esophageal spasm. Again, fairly rare, not a very common thing to happen, and can be reduced by having acid-reducing medications, which we'll talk a lot about in the next two slides, including Tums, which would be the weakest, and moving up to Pepcid and Tagamet. Those would be the kind of middle of the road, and up to the strongest ones, which would be Protonix and Omeprazole and those type of medications. Here's a camera looking down an esophagus that has a lot of inflammation. It should be pink and smooth, and you can see there's little ulcers there of inflammation, and this is an esophagus that is not feeling good. This patient would feel a burning in the chest pretty much all the time. Esophagitis is a flare-up of the esophagus from any number of reasons. Most commonly would be acid reflux coming up from the stomach that comes all the way up, and it's kind of continual. So here you would know it's not your heart because, again, you would have pain all the time, not related to going upstairs or moving around. And that pain gets better when you eat, which can kind of soothe the esophagus, or it gets better when you take antacids. Again, patients typically present with ongoing pain for days that's not related with any movement that they're doing. Even with these symptoms that don't sound like a heart, we always have to make sure that it's not a heart attack, again, because some patients will present with daily pain, or they may have a combination. They may have heart disease and an esophagitis, and so we need to rule out and make sure they're not threatening to have a heart attack. Again, this is treated by the same antacids we talked about. Again, Tums or something like that over the counter would be the weakest. Middle of the road strength would be Pepcid and Tagamet, and then the stronger ones, Omeprazole, Protonix, and there's a bunch on the market, some of which you can get over the counter. Finally, dealing with the esophagus, the most common GERD, gastroesophageal reflux disease. That just means acid coming up from the stomach. You can see in the picture to the right, acid coming up. That's because the closing device, the band of muscle at the bottom of the esophagus, right where the stomach connects, is not closing as well as it should. So very common that almost all the patients I have in clinic probably have some form of reflux, as well as little children. We're finding out it's much, much more common than we ever thought, and causing a lot of troubles that we thought were related to something else. This has a myriad of complaints. You don't necessarily have to have an acid taste in your mouth or actually be refluxing all the way up to the mouth to have reflux. Much of it will stay in the lower portion of the esophagus and will be causing chest pains or heartburn, and people are not sure what it is. And of course, you always have to rule out a heart attack, like we said before. You don't want to miss. A threatening heart attack, but this is so common that most patients I see where we've ruled out heart attack, I just tell them to start an acid-reducing medication to see if their chest pains will go away. And most patients, their pain will be relieved in 3 days taking a pill like Pepcid or Tagamet or one of these over-the-counter antacids that are a little stronger than Tums or something like that. Again, very common. Can be serious. If it's serious enough and it's bad enough, you know, the GI doctors, the stomach doctors would need to take a look down there and make sure things look okay. The next common complaint or worry for people is whether or not they want to know whether or not they're having a panic attack. This is a very difficult diagnosis. Usually, the most people who have a history of anxiety and panic attacks, they know exactly what a panic attack is when they're having one. They've had them since they were a teenager. Some people get diagnosed later in life, but I'd say that's pretty rare. Most people have a history of panic attacks, and so it makes it a little easier for the doctors to know, when they say, well, I've had a history of panic attacks. Now, even someone who's had a history of panic attacks, if they come in complaining of chest pain, always wish to make sure they don't have a heart attack so we don't miss it. I think I've drilled that in enough today. Here are the criteria for a panic attack. You can see multiple complaints that can occur. Typically, from my perspective, a true panic attack kind of comes on with a trigger. Sometimes it can happen without a trigger. It's usually a band-like pressure across the chest. It doesn't usually radiate to the jaw or arm. It's usually a band, like if someone's squeezing your chest with a rope or something. And always associated with anxiety and heart racing and these other symptoms that you can see here. Now, again, many things would need to be ruled out before a diagnosis of panic attack is given. We want to make sure that your heart is okay, that your esophagus is okay, lungs, and the big blood vessel in the chest, the aorta, is okay before we say, well, this is all anxiety and a panic attack. Now, these can be a serious medical condition and paralyze patients, and there's good treatment for this, and it should be sought out. There's good medication that has been proven and does decrease the events, the panic attacks in someone's life. Another common reason for chest pain is what's called pericarditis. You can see in the picture to the upper right, the heart actually has a nice thin lining of protectant lining called the pericardium. Peri meaning around, cardium meaning heart, so it's just a layer of tissue that's actually kind of slimy and slippery, so the heart can beat in there and slime around and not be adhered to anything outside. It just has kind of free floating in this lining, which allows it to move and pump and do its job. That lining can become inflamed by a virus, by autoimmune diseases like lupus, by a myriad of other issues, and when that lining becomes inflamed, it hurts, and it presents as chest pain. It's usually a steady chest pain all the time, usually occurs in people that are younger, and you can usually tell this because when people take a deep breath in, it hurts. It can change whether it gets better or worse moving around. Unlike heart attack pain, which comes with exertion or is severe if there's a threatening heart attack, severe, and doesn't matter where you move or where you push or how you change your body, it just hurts. With pericarditis, you really can get some relief by sitting up. Hurts worse to lay flat. And again, it would hurt with breathing. You can see a CT scan on the bottom there. There's a thick kind of layer where that arrow is pointing, much too thick pericardium. The layer around the heart should be thin and almost invisible. Here there's a patient who has a history of long-standing inflammation of the pericardium or pericarditis, and now it's become thickened, and this becomes a problem down the road. The heart is unable to beat like it should. Pericarditis, in almost all cases, goes away on its own. It's treated with NSAIDs, which is a lot of ibuprofen, and some other anti-inflammatory drugs. Again, it's more common, not as common as heart attacks or reflux disease, but it is not rare. We'll probably see, in my clinic, at least 5 to 10 per year. Typically, most people are young and they've had a recent viral illness, and then they come in complaining of chest pain. Again, this usually goes away on its own. No long-standing damage, typically, and treated with anti-inflammatories like ibuprofen. A serious reason for chest pain, and one we don't talk about, is called aortic dissection. The aorta is the large blood vessel in the chest. If you remember, John Ritter died of this disease, and unfortunately in his case the doctors there thought it was a heart attack and were treating a heart attack, and it turned out it really was an aortic dissection. There's ways to split them apart, tell them apart in the ER, which our doctors here are very good at. It's usually diagnosed by a CT scan. People have a ripping, tearing feeling through the chest. Usually starts in the back and heads to the front, or starts in the front and heads to the back. It's a severe tearing type symptom with heart racing and an impending doom feeling. This is not something that many people survive. Luckily, it's rare. There are a few people that will have that tearing sensation and pain in the chest and survive and have it surgically fixed. You can see in the CT scan on the right where the arrows are, that should be all white. That's dye inside of the big blood vessel, and you can see there's a little line in the middle of that blood vessel, meaning that wall has ripped away from the side of the vessel, and now there's basically two lumens or two holes where the blood can flow, and that's a dangerous situation where the vessel can actually rupture and break open, and patients do not survive that. So this is rare, but something to keep in mind of. This would be all of a sudden this would be at rest. You have a ripping, tearing feeling, and you would want to call 911. And this usually happens in elderly patients. We can't forget about the lungs. They are also in the chest cavity there, and they do cause different things, can cause chest pain related to the lungs, although fairly rare, at least from a cardiologist perspective. Some people will get a blood clot in their lungs, which can cause some chest pain. That's usually fairly easy to pick up because the patient is so short of breath and has had some recent travel or some other reason for having some other trigger for a blood clot in the lungs. Again, fairly rare. Also, pleurisy we should talk about. This is something we do see pretty commonly here. If a patient who's had a virus or a chronic cough or a pneumonia, the lining around the lungs, which is called the pleura, can become inflamed, much like a pericarditis or the lining around the heart. When that happens, people get kind of low rib pain on the right or left. Usually you can tell it's almost like having a broken rib. When you cough or breathe, it hurts. Every time you take a deep breath in, it hurts. Every time you cough, laugh, move, it hurts, or it can just hurt all the time. This is treated with anti-inflammatories like ibuprofen. Again, a heart attack would need to be ruled out, but this can be a common finding as well, in particular people with lung disease. Pneumonia can also hurt. Usually pneumonia causes pleurisy, and that's why you have pain. And of course, if you're a smoker and elderly and you have chest pain, after all these things have been ruled out, we do need to think about lung cancer, which can cause pain. I'll take any questions now. If you have the ability to type in and you want to ask some questions, you can. We'll just give a minute or two. Remember, this can be viewed. We've recorded it. It can be viewed on the website at any time to go back through it. Great. Well, we appreciate you joining us, and we hope to have more in the future, and I hope you have a good day. Thank you.